Start. Okay.
Yeah. Fridays are tough because, since you're not on Fridays anymore, and since the interviews now, Fridays are like not just the PFPs and exercises, but checking and doing patient consults also for all one time. So I've been spending here till like 7 or 8 o'clock a lot of Fridays the last month or two. No, I kind of put it next Wednesday because of the weather. I haven't been able to get out the last 3 or 4 weeks. It's been so much other. But I'm hoping I can maybe get out this weekend. But I'm not sure what you like. Interested in going out maybe Saturday, Sunday, or Sunday,
All right, good afternoon, everybody. I'd like to go ahead and get started. For our applicants who don't know me, my name is Jennifer Butler. I'm one of the second-year pulmonary fellows. I'll be talking about our pulmonary lecture today entitled Management of Acute Exacerbations of COPD, an Evidence-Based Approach. COPD is a huge topic. There's like thousands of literature and papers out there. So I tried to skew this down as much as possible to kind of just focus our scope on some salient points and things that I thought were interesting. So the overview that I want to be able to give you today is kind of define what is a COPD exacerbation, kind of go over the risk factors, review the classification scheme put forth by the American Thoracic Society and the European Society Task Force in 2004. I want to be able to review the acronym that I created for management. We're going to review a piece of evidence supporting oxygen therapy, 2 studies looking at steroid therapy, and then also looking at antibiotic therapy. Okay. So a little bit of background on COPD. According to the American Lung Association, is the 3rd leading cause of death in the United States. Over 130,000 Americans have lost their lives to this disease. A current lung association revealed that half of our COPD patients feel that their condition limits their ability to work, limits their normal activity in terms of physical exertion, household chores, social activities, sleeping, and family activities. This is actually the 11th consecutive year in which women have exceeded men in the number of deaths attributed to COPD. And actually in 2010, more than 70,000 women died compared to more than 64,000 men. So I thought that was interesting. So a lot of times we can think about COPD, we tend to focus on men and not our women.
Can you think of the reason why that statement is true?
It's hard to say. I think in some of the literature that I looked at, women are diagnosed later. Women are underdiagnosed, and sometimes they're labeled as asthmatics and they're not labeled as COPD. That's one possibility. You had another reason, Dr. Qualley?
Well, one that comes to my mind when I read your paragraph there was muscle mass of men being greater than women and respiratory failure more likely to be associated with lesser muscle mass.
The American Lung Association, when they talked about their health disparities project, linked women in with minorities. And one of the things that they did talk about is they felt that sometimes clinicians, especially primary care physicians, were either underdiagnosing or misdiagnosing women for COPD. And then, of course, when we look about the cost to healthcare in 2010, COPD was projected to be approximately $49.9 billion, including $29.9 billion in direct healthcare expenditures, $8 billion in indirect morbidity costs, and $12.4 billion in indirect mortality costs. So how do we define a COPD exacerbation? The definition I took was from the 2004 ATS and ERS proposition paper, and they define an exacerbation as an event in the natural course of the disease characterized by a change in the patient's baseline dyspnea, cough, and or sputum that is beyond the normal day-to-day variations, that is acute on onset, and then warrants a change in regular medication. And some of the risk factors that we think about include air pollution, advanced age, infection, environmental conditions, having one of the major comorbidities like heart failure, ischemic heart disease, duration of COPD, history of antibiotic therapy, COPD-related hospitalization within the previous year, cigarette smoke, and then chronic mucus hypersecretion. So I thought this graph was pretty interesting. It was originally quoted in a study from 1979 by Dr. Taggart, and the ATX actually quoted it when they were looking at the effects of different exposures on normal lung function. So we know that in normal lung development, you have increased growth during childhood and during adolescence. You have a peak at about the age of 20, and then you start to have a plateau off. And then around the age of 50, you start to have a decline, which is normal in as we age, and which is normal as a part of the aging process. But when you look at things like air pollution, diet, passive smoke, biomass, even TB, if they start to have an exposure on people as young as the age of 5 or 10, they can actually start to cause a decrease in your FEV1, which results in a shortened plateau time, and then also results in an early or accelerated decrease in their FEV1. So they may become earlier predisposed to developing COPD later in life. So the task force in 2004 came up with an operational classification for severity to help rank the clinical relevance of each COPD exacerbation episode and its outcome. Level 1 was considered patients that could be treated at home. Level 2, patients that required hospitalization. And then level 3, people that probably would require ICU monitoring for respiratory failure. And what they basically found with an outpatient treatment, these patients needed to be educated properly. You need to make sure that they understood the type of inhalers that we're using, and then they were also using proper inhaler technique. Of course, you're adding bronchodilators as needed, and also steroids if needed as well, and we'll get into that a little bit later in terms of dose and duration. And then also antibiotics. And antibiotics should always be chosen based on your local community bacterial-resistant patterns. Level 2, for people in the hospital, we're also still using bronchodilators, steroids, and antibiotics. And then level 3 are usually our patients in the intensive care unit that require supplemental oxygen, ventilatory support, bronchodilators, corticosteroids, and then, once again, antibiotics. So our patients who are in the ICU often need additional ventilatory support. We often think about things like BiPAP, which is non-invasive ventilation that helps supporting them during an exacerbation. And if they start to fail BiPAP, meaning that they can't tolerate it or they have contraindications for it, then invasive mechanical ventilation should be administered. So the cornerstones of management are really antibiotics, bronchodilators, corticosteroids, and oxygen. And so we'll look at the evidence supporting these major players. So let's start with oxygen because it's just the easiest. We all know that supplemental oxygen is a critical component in acute therapy. But a lot of times we suffer from a culture of much is better, more is better. And sometimes when we do that, we're giving our patients a disservice. So a number of trials and studies have looked at what should be the ideal target for our COPD patients. And the target that they came up with 88% to 92%, or an arterial oxygen tension between 60 to 70 millimeters of mercury. And so we'll actually look at a study that kind of supports that particular guideline. So this is an Australian study that was published in the British Medical Journal in 2010. And it was entitled The Effect of High Flow Oxygen on Mortality in COPD in Patients in a Pre-Hospitalized Setting. So it was a randomized controlled trial in the Tasmanian state of Australia. And they used their ambulance and paramedic workers to be responsible for randomizing patients into either a control arm or active arm. Patients that were in the control arm actually received 8 to 10 liters of oxygen via a non-rebreather, and they also received bronchodilators nebulization via oxygen with 6 liters. Patients that were in the active arm actually only received titrated oxygen via nasal cannula, and they always tried to make sure the SpO2 was between 88 and 92%. So, interestingly enough, when they actually looked at their analysis for these patients, they found definitely a statistical difference in mortality between their control group and their active group. In the patients that received high flow oxygen, the mortality was 9%, compared to those in the active group, it was 4%. Also notice the incidence of invasive ventilation, much higher in the control group compared to the active group. And then length of stay really didn't differ much between the two treatment arms, but if you actually look at your ABG, you can see a significant difference between your respiratory acidosis. Your pH in the control group was 7.29 compared to the active group, which is 7.3. And even when you look at your mean CO2 levels, 77.8 in the control group and 54.7 in the active group. So definitely our control group with the higher oxygen has worsened respiratory acidosis and a higher CO2 level. Two limitations that the authors really cited with this trial was a low rate of adherence to the study protocols in the pre-hospital oxygen treatment plan. So basically what happened was when the paramedics would respond to somebody that was in a COPD exacerbation, they were never really quite comfortable with somebody statting at 88% because of this culture, more is better. So they tend to break protocol and always turn up the oxygen to make somebody stat above 95%. So that was one limitation. The second limitation was the low rate of ABG blood gas sampling for patients in the ER. A lot of time emergency medicine physicians didn't feel that it was indicated, didn't feel it was warranted. So a lot of their patients didn't even have ABGs drawn for analysis. So when we pull back, what are the things that we really should take away from this study? Definitely we have strong evidence that titrating oxygen should be used for our COPD patients. We want to keep our goal between 88 to 92% because they did have a lower mortality rate. And you also notice that the high flow oxygen patients were more likely to have respiratory stenosis with a significantly higher CO2 pressure. Any questions on that study?
I'm not sure that study is good enough to convince us not to give oxygen. Maybe, I don't know.
Yeah.
Do you feel like all the respiratory acidosis you treat in the hospital or the ICU are just because we're giving more oxygen? Or?
Well, this is pre-treatment, pre-hospitalized patients. I think that a better study probably that I could have told was the Narntopoulos study, the physiotherapy, because I think what he did with his study may have probably shown a better result. So maybe I should have gone through that. I can actually print that off and give that to you. All right. So we'll move on to talking about corticosteroids. So what do we know about steroids so far? It accelerates improvement in airflow. It definitely helps to improve gas exchange. It helps to improve symptoms in our patients. And it helps to reduce the rate of treatment failure. And a number of studies that I quoted here have proven that over time. One of the biggest studies that really looked at the effect of systemic steroids on exacerbations was actually published in the New England Journal of Medicine back in '99. This was called the co-op study through the Veterans Affairs Cooperative Study Group. And they actually had 25 VA centers participating with patients having COPD exacerbations. I listed the inclusion criteria here for you and also the exclusion criteria as well. So the methods that they used is they took 271 veterans and randomly assigned them to 3 treatment groups. Each group received a 3-day course of IV methylprednisone, 125 milligrams every 6 hours. The recipients of the steroids were then further divided to have a dose of oral prednisone tapered either over a course of 15 days or 8 weeks. So group 1 was 15 days, group 2 was 8 weeks, and group 3 was placebo. The major endpoint that they were focused on in this study was to discover the time to first treatment failure. And they defined treatment failure as death from any cause or the need for intubation and mechanical ventilation, readmission because of a COPD exacerbation, or intensification of pharmacological therapy. And so when you actually look at the Kaplan-Meier curve that they were able to produce, treatment failure against time in months, you can see that patients that were in the corticosteroid group were lumped together, and they seem to do much better than patients in the placebo group in terms of treatment failure. Secondary endpoints that they also looked at were changes in the FEV1. Patients underwent spirometry at baseline at days 1, 2, and 3, and at 2-week, 8-week, and 6-month visits. They also looked at length of hospital stay and death from any cause from 6 months follow-up. So what I thought was pretty interesting about this group is that when you look at patients that are in the placebo arm versus the steroid arm, it seems that patients in the steroid group tend to have a significantly faster increase or improvement in their FEV1 compared to the placebo group. What the authors did note was at day 1, there was a statistical difference in that patients in the glucocorticoid group had an increase in their FEV1 only by 0.1 liters. But when you follow this out to about 2 weeks, there was no statistical difference. So what do we draw from this particular study? We know that the steroid group had fewer treatment failures. Patients who received corticosteroids had an FEV1 that was slightly but significantly higher. We had shorter hospital stays in the steroid group. And then outcomes in the 8-week group of steroids was no different than those that received a 15-day course. Any questions about this study?
Are you going to talk at all about intravenous steroids in the first phase of treatment versus oral steroids?
No, that's not a part of my talk.
Is there any data that suggests one is better than the other?
You know, I looked at a study, and I can't remember if it was in ATS or the New England Journal of Medicine. And in that particular study, I think they were looking at the combination of antibiotics and steroids. And in that particular study, they had all of their patients receiving 7 days of IV Solu-Medrol. And they reported that the FEV1 was significantly improved compared to patients that received oral prednisone at 40 milligrams. But I can't remember the actual paper, but I looked at that. That was a little while ago.
There's actually been several studies done over the years on that, and what they've all concluded is you probably get to the same endpoint, just IV gets in there a few hours faster. Is that your understanding too, Paul?
Yes.
Yeah.
In patients without respiratory failure. Because I think
Yeah.
people take that
Yeah.
data, and I notice when I'm around in the ICU now, everybody's getting 40 of prednisone. I'm like, hold on, I'm telling you, medications for respiratory failure, you can take them more aggressively, but that data really is for, on patients not in respiratory failure with the COPD exacerbation.
How about the 45 days? Okay.
You talk about duration?
Yeah.
Yeah, we're gonna. Okay. So the question is, we know that steroids. Sorry. No, go ahead. What's your question?
I just said it.
Side issues.
Yeah.
Okay. So we know that steroids work, but the question is, how long should we be giving them to our patient? So is this going to answer your question?
Yeah.
Okay. All right. So we're going to talk about the reduced trial that was brought forth by JAMA. And so they looked at eligible patients that were randomly assigned to either 5 or 14-day courses of systemic steroids. All patients initially received 40 milligrams of IV methylprednisone on day 1, and then followed by 40 milligrams of prednisone daily from day 2 to 5. And then those patients in the 14-day course received the placebo days 6 through 14. And I just put the flow chart for you to see that they initially had 717 patients assessed for eligibility, assessed to be eligible. 314 were actually randomized. And then the short arm were patients that received 5 days of steroids, and then the longer arm were patients that received 14 days. So, interesting enough, what I thought was something that I thought to highlight was that every patient in the study, regardless of what treatment arm that they were in, received broad spectrum antibiotics for 7 days. They all got nebulized short-acting bronchodilators 4 to 6 times daily as needed. They all got inhaled glucocorticoids twice daily in combination with a LABA or long-acting anticholinergic medication once daily. And then they all received physiotherapy, supplemental oxygen, and then ventilatory support is needed as well. The endpoints that they were really looking at this study was time to the next COPD exacerbation during a follow-up of 6 months. And they defined that as any acute clinical deterioration beyond the usual day-to-day variation requiring interaction with a clinician. The secondary endpoints that they also looked at were all-cause mortality, change in FEV1, cumulative glucocorticoid dose, and clinical performance. So they used the Kaplan-Meier graph to kind of illustrate their findings for time to next re-exacerbation for COPD. And I thought what was interesting was that the longer courses of steroids really didn't make a difference in reducing the rate of COPD exacerbations. And a part of the data showed that patients that were actually taking the 14-day course had an exacerbation rate of 37%. And then those patients taking the 5-day course had an exacerbation rate of 36%. So not much of a difference there for them. The limitations of the study that I was concerned about was that all the patients, regardless of what their goal classification were, all received triple therapy with a LABA, an ICS, and then an anticholinergic. And then all the patients, regardless of what their sputum production, received antibiotics. So it makes me kind of wonder if that may have kind of skewed the results that they end up having.
Can I tell you my problem with the study?
Yeah.
It's our endpoint. Okay, when we treat patients with exacerbation of COPD, it's not to try to prevent them having exacerbation 6 months later. We're trying to make them feel better.
Yeah.
Okay, and I think one of your first slides, you could kind of dovetails with this also, in that they, even if you don't treat them, your placebo groups eventually get better also most of the time.
Right.
I mean, our object is to make that sick patient feel better relatively short, within maybe days to a couple weeks, not smooth along for 3 months like the placebo group. Yeah, they all get to that same endpoint 6 months later, but that's not the endpoint with any of us who are treating COPD. Trying to make that guy that's sicker and crappier in the spot feel a lot better sooner, not where he's going to be 6 months. So I have a real issue, because now we got everybody under God's creation giving 5 days of prednisone for exacerbation of COPD to prevent something from 6 months later. And I'm seeing all these patients come floating back in internal medicine in my clinic now after they've been discharged. I got to give more prednisone because they still feel like crap. Though it's 6 months, they'll probably be at the same point. So we got to look at what we're doing on this study. I think that
agree
endpoint.
with you. I think that's the biggest mistake general internists make in managing people with acute exacerbations of COPD. And I think many of the patients, in order to feel better, need steroids for a longer time.
Right. You know, they don't care if 6 months down the road. They want to feel better now, and that's what we're trying to do, is get them to feel better as quickly as we can to get better. So this 5-day thing, I think everybody's going to it because of this study here.
Yeah.
I think it's nonsense.
So, Jennifer, do your slides on the baseline characteristics for these patients
I
in terms of
no,
where,
I didn't pull
how
this
severe
up.
they were on
Right.
triple, they're on triple therapy.
Yeah.
How well controlled they were going in, because a lot of our population aren't well controlled coming into these exacerbations.
Right.
And that's where maybe another place where the longer duration of steroids may be
They
beneficial.
didn't break it down that article either. I remember that.
It's fair. That part to me, I'd like to see a little bit more
Yeah.
before I say I'm comfortable shortening up, but I think that it's certainly worth discussing.
Yeah, I should have probably, you're right, I should have put the baseline characteristics up here for us to go
They weren't really very clear in
through.
the article itself on that.
Yeah.
There were kind of a lot of gray zones in there.
Yeah. Okay.
So Dr. Morris, you give 10 days?
Excuse me?
You go for the 10, you give 10
You know,
days?
a lot of times I tailor it to the individual patient, because, you know, I've had experience with a lot of these people, how long did it take them to get better before? Can I do it in 10 days versus 3 weeks? You know, how sick are they? I put a lot of variables on how well the patients tolerate prednisone. Sometimes patients have been on it a couple times, you educate them. You give them like 40 milligrams a day for like the first 5 days, and then depending on how quickly they respond, give them some advice. Well, you don't have to go down to 30 for 4 days, maybe go down to 30 for 2 days and 20 for 2. You know, I give them parameters. If they're feeling really good, well, go faster than lean it because they don't like the side effects. So, but you can only do that if you really spend a lot of time with your patients, you educate them, you kind of get a feel for them. And a lot of these patients, I'm dealing with exacerbations, hundreds of them for a decade now too. So you get to know your players pretty well.
And the in-hospital guidelines for this institution now are 10 days at 40, and we have leeway to change that if we feel like someone's been terribly controlled for months, and that we want to do more of like a taper down and maybe more like 2 weeks, we have that leeway, but we'll get called by the inpatient COPD team and the pharmacy team about that. But now it's because before they were having, they felt like they were having so many readmissions because of that short course, the 5-day, that they actually have asked that from the hospitalist and the internal medicine groups, we don't have to necessarily go to those criteria, but they've asked that those patients get 10 days. If you're a 10-day course of 40 of prednisone, to try to make it as simple as possible. Granted, I think that's sort of a compromise, and I'm sure there were lots of conversations that went into that, but that's sort of what's being done in the institution now.
So are you guys noticing that there's a decrease in readmissions?
No, we have plenty more. They're still tracking. They're still data tracking, but we've seen so many that were on the ventilator would come out and go to V2 or something, and they would only get 5 days. They'd be like, oh, they got like 5 days, they're good, and they would stop them. And so, it sort of depends. I think Dr. Morse brings up a good point. It depends on sort of the severity of illness, but I think that they felt like we were undertreating. The global sense was that the patients were being undertreated, but it's being followed. We have so many other interventions we're doing to minimize the readmission rate. It's one of the targeted areas that it'll be hard to tease it out. Because patients weren't leaving on appropriate inhaler therapy either. I mean, again, we're not really sure what patients were getting. So I think it's multifactorial. So I don't know that we're going to be able to tease it out.
How many are doing cocaine and seeing
Exactly right. And so we also, or if they like ran out of their inhalers and came in. Yeah, no. If they ran out of their inhalers and then come in and you feel like, geez, I just need a couple days to get back on their inhalers, we change it in that setting too.
Because I think this is one of the ABIM's big push with the Choosing Wisely campaign too, is to use oral. I feel like I've seen it all over their website, and to do a short course as opposed to a long course.
I wish they again characterize the patients a bit better, and again, this is maybe a better insured population, so I think that those factors aren't well accounted for. So I'd like to see more. It'd be great if we could, but I've not been convinced.
Thank you. I agree.
Okay. So major findings from this study, when compared to a 14-day systemic steroid course, 5 days was non-inferior in the 6-month re-exacerbation rate. There was no difference in mortality, no increased need for mechanical ventilation between treatment regimens. Perhaps taking longer courses of prednisone doesn't help, and maybe we should stop over-treating our patients. That's controversial. And patients in the 5-day treatment group received a lower cumulative dose of corticosteroids during the trial, but there was no difference in the steroid-related adverse effects. So moving on to antibiotics. One of the classical studies that a lot of people in the literature quote is the Endothecin Annals of Internal Medicine study published in 1987, entitled Antibiotic Therapy and Exacerbations of COPD. In the study, 173 patients with a COPD mean of FEV1 33% were monitored for 3.5 years. When exacerbation developed, patients were given a 10-day course of either placebo or antibiotic in a double-blinded manner. And then patients were also given 40 milligrams for 3 days, and the tapering dose between 9 to 12 days is needed. The antibiotics that they used were Bactrim, amoxicillin, and doxycycline. Each exacerbation was followed closely for about 3 weeks, then at a 3-month interval in the clinic, and then reevaluated yearly. The inclusion criteria were patients that were at least 35 years old, had a diagnosis of COPD and not asthma, had an FEV1 FEC ratio less than 70% predicted value, and a TLC greater than 80%. The exclusion criteria was anyone with an FEV1 increased to 80% predicted with the use of a bronchodilator, and then if they had diseases serious enough to influence quality of life, like cancer, stroke, or heart failure. Each patient at the end of 3 weeks had a chest x-ray and PFTs. So in his study, he makes 3 categories for exacerbation. Type 1 is a patient with increased dyspnea, sputum volumes, and sputum purulence. Type 2 is 2 or 3 symptoms, and type 3 is 1 of 3 symptoms. And when we look at the outcomes data for antibiotics and exacerbations, we find that the success rate in the antibiotic group compared to the placebo group is at least 1.5 higher. So 68% in the antibiotic group compared to the placebo group. And then when they looked at the first exacerbation success rate, you had a percent of 66.8% compared to 52.3 in the placebo group. Another measure that they looked at was recovery of peak flow. So at the time of onset of an exacerbation, most patients, their peak flow dropped down to 190 liters per minute. And then as they started to be treated with antibiotics, they felt that they saw a greater increase in their peak flow in patients that got the antibiotics in the open circles compared to patients with the placebo. So from his particular study, the major conclusion was the use of antibiotics in the presence of a type 1 exacerbation increased dyspnea, increased sputum production, and increased sputum purulence, improved outcomes. Any questions on that particular study? Okay. So what about using antibiotics in addition to steroids? We'll look at the ATS journal study done by Daniels et al., published in January of 2010. And basically the study design was a randomized double-blinded controlled study where they used doxycycline in addition to systemic steroids for patients hospitalized with an acute exacerbation of COPD. And the goal was to assess the effects of doxycycline on clinical and microbiological response, symptoms, lung function, and systemic inflammation. They used C-reactive protein to measure this. So the patients that were laid out was that they had 367 patients that were screened. Only 265 actually underwent randomization. 128 were assigned to receive 7 days of doxycycline, and then 137 were assigned to receive the placebo. Patients also received steroids starting at 60 milligrams per day and were tapered down over a 7-day course. They also received nebulized bronchodilator therapy and physiotherapy as needed. On days 1, 10, and 30, patients were assessed clinically via blood samples and C-reactive protein, serological testing, spirometry, and expectorated sputum samples.
What is serological testing mean?
Oh, they were just like CBC, looking at their white count. The primary endpoint was the clinical response at 30 days, and the secondary endpoints that they looked at were clinical success at day 10, clinical cure at days 10 and 30, antibiotic treatment for lack of efficacy, lung function measured by a change in FEV1, time to treatment failure, serum reactive protein, symptoms, and microbiological response. So when we look at the intervention for patients in the placebo group compared to doxycycline, we can see that for clinical success on day 30, the difference is not that big. Doxycycline is 78%, placebo was 72%. But when you look at their secondary endpoint of clinical cure at day 10, definitely a bigger improvement, 86% in doxycycline, placebo is 69%. And they describe clinical cure as complete resolution of all symptoms, not just improvement. They also were looking at the FEV1 at day 10, not that much of a difference, but at day 30, they saw a difference with the antibiotic group compared to the placebo group. And then they also were measuring, as I said, CRP as a way for, as an anti-inflammatory marker. So when we look at the subgroup analysis of the patients that did the best with doxycycline, with steroids, patients that had the type 1 exacerbation, those 3 cardinal symptoms, did the best out towards day 30. and also patients that had a very high inflammatory marker, CRP greater than 50, did better as well. The FEV1 groups were about the same, and bacterial presence about the same as well. And this was just a quick look at the bacteriological response of the different pathogens that they were able to isolate in all of their patients, and the bactericidal response of doxycycline compared to placebo. Sorry. Any questions about that particular study? Okay. So when we look at the guidelines that the ATS task force put forward, and we look at the guidelines that Gold talks about, people mention a number of different antibiotics we can use. When starting off with an exacerbation, we find that a lot of people tend to lean towards the macrolides, or they lean towards doxycycline. So the question was, is there any superiority of antibiotics one over the other? So one of the studies that I found was something called the Mosaic study, written by Robert Wilson et al. In chest. And they were looking to see if there was a superiority of using moxifloxacin over standard treatment antibiotics. And they wanted to see if there was an effectiveness difference in using standard antibiotic therapy in acute exacerbations. So the standard therapy he classified as using clarithromycin, amoxicillin, and cefoxiamine compared to moxycycline. And when they looked at the bactericidalness in vitro, it seemed like when you looked at your gram-negative organisms and your gram-positive organisms, moxy seemed to have a better MIC compared to the other three. And when you also looked, I'm sorry that this is not as clear as it should be. When you also looked at clinical efficacy, they were judging clinical success and also clinical cure. So the authors actually define clinical success as resolution and improvement. They define clinical cure as to whether or not there was complete resolution of symptoms to baseline. So when we look at clinical success in moxy compared to those standard antibiotic drugs, moxy has a greater percentage, 87.6 compared to 83. When you look at clinical cure for moxy, however, meaning complete resolution of symptoms, the patient's completely back to baseline, moxy does much better, 70% compared to 62% at those other drugs. And this was just looking at patients at a time period further out, 10 months along the way. And basically they were just showing that they felt that patients at a six-month mark receiving moxy and beyond seemed to just do much better than the comparator group. So pulling from the study, the findings they felt were that moxy was equivalent to the comparator regimen for the primary measure outcome of clinical success at 7 to 10 days. But when you talked about clinical cure, complete resolution of symptoms, and bactericidal eradication, moxy was actually superior. And then the failure rates were significantly lower in the moxy group at 7.6% than in the comparator group at 14.1%. And then longer-term outcomes from the Mosaic trial show that moxy was also superior in comparators in terms of lower relapse rates.
Yeah, Jennifer, I think this is another one where severity of illness, like number of exacerbations in the past year, often they're treated with antibiotics, gives you, I think, also puts this into context in terms of individual, sort of trying to apply it to patients in general, because we're still not typically using it as first line. And granted, I think we overuse, let's say, doxycycline.
Yeah.
I also think we overuse quinolone. So I think, again, having that background of where those patients were at, kind of going into this, I think it's probably, I haven't read this in a really long time, but it's all sort of an all-comer study. But I think maybe that's where teasing it out a bit more might be helpful.
And they always use a disclaimer that you still have to go by what's your community resistance patterns at the end of the day. So,
chronic use of chronic use of azithromycin to reduce exacerbation rates. Have you come across that?
I did more as a maintenance therapy, not for acute management, like in the quick outpatient
That's like
setting
its
or
own hour.
inpatient. Yeah.
What's that?
That's its own hour.
Yeah, that's a fun
Yeah.
topic.
They'll get kind of heated.
So, you describe that patients with low FEV1 has high incidence of pseudomonal colonization. So the question is, this patient with very low FEV1 should be treated also with an anti-pseudomonal agent in addition for COPD exacerbation, or should we use that in addition to the macrolide, or should we take the macrolide and give the anti-pseudomonal only if the patient has history of pseudomonas?
I think at the end of the day, you still go by what you know your patients probably colonized from previous sputum cultures and what you know to be your local resistance patterns. We know patients that have a lower FEV1 are probably going to be more likely to be at risk for pseudomonas exacerbation. Especially patients coming into the ICU, you probably want to be aggressive first, and then you can always step down therapy later based upon what your cultures come back to be. So this drug, while is actually being talked about more for maintenance therapy rather than acute exacerbations in the hospital, I just thought I'd just throw it in to get our staff's opinion on it. So Roflumilast, new kid on the block, relatively so, is a phosphodiesterase 4 inhibitor. The mechanism of action is that it reduces inflammation by inhibiting the breakdown of intracellular cyclic AMP. No known direct bronchodilator activity, but has been shown to improve FEV1 in patients treated with a LABA or a anticholinergic, long-acting. Various studies like the one I list below show that it reduces moderate to severe exacerbations by 15 to 20% in patients with chronic bronchitis and severe COPD. So one of the studies that really looked at the effect of this particular drug on COPD was published in The Lancet in 2009. And it was a 2 placebo-controlled double-blinded trial at 2 different centers. The first study looked at our study drug with salmeterol, and then the second study looked at our drug with tiotropium. I just put the first study here for the interest of time. The study designs were similar and the results were similar. But basically, they used patients that were older than the age of 40, that had severe airflow limitation, that had bronchitis symptoms, that had history of exacerbation. They were randomly assigned to receive either Roflumilast 500 milligrams once a day or placebo for 52 weeks. And the primary endpoints that they were interested in looking at was to see if there was any major change in spirometry in FEV1. And when you look at the pooled analysis that they gathered for patients that receive our study drug with a LABA, they actually had a pre-bronchodilator FEV1 increase by 48 milliliters compared with placebo. And also they found in this study that the rate of exacerbations in moderate to severe COPD per year was actually reduced by 17%. And I just put that outcome slide there for us as well. Any questions in particular about the?
Got all kinds of issues, but I'll wait for you to finish your
I guess my question was, because I haven't started really using that particular drug, how often are we using that as maintenance therapy for our patients in the clinic?
I find that I have patients that are on it that have been started by someone else. I think the issue with this study and the other study that's out for this is that you could argue that those patients are suboptimally treated for their COPD. If they're that severe, why are they only on a LABA?
Right.
So, and then I don't know why, I guess it's hard for me to sort of justify giving that to patients when that side effect profile, the diarrhea is not uncommon.
Yeah.
And a lot of patients stop it for that reason.
Right.
So I think it would be interesting because, you know, with the other PD inhibitor, when you look at something like, I'm not remembering it one, theophylline is another PD, right? Still PD pathway, I think. When you look at that actually may improve steroid responsiveness. So I actually think it would be better to look at it with that. But when you know you have meds that improve your dynamic hyperinflation in combination with ICS-LABA plus LAMA. Why would I use this over that when those individual ones actually reduce exacerbation rates on their own? And the combination of LABA with an ICS is certainly better than a LABA alone. So I don't know why they picked, because I think they knew it would be probably harder to tease out a difference, but practically speaking, I think it's hard, and I wish that next study would come out where you see if it does add benefits. So for your patients that still are the ones maybe you would have considered for theophylline before, that still would be an option for them. But I think the side effect profile probably is the limiting factor for a lot of patients.
Yeah. So, I mean, they talked about a lot of the GI symptoms like nausea, the diarrhea, the abdominal pain. They also talked about weight loss that they saw within a year. People had like a 2.5 kilogram weight loss, which may not be so bad for our obese patients. Sorry.
My problem is it goes even beyond that. We're talking about a drug by most formularies is a tier 3 drug. And for a drug that really doesn't improve them acutely, for the goal to maybe prevent an exacerbation 6 months down the road, to pay an extra $100 copay a month for something they're not going to feel any benefit from, they might get lucky not have an exacerbation. Most of my patients say, screw that, I don't want it, too costly, I don't like the side effects. Just give me give me a week's worth of prednisone in 6 months and for $5 and I'll be fine. And that's the attitude most patients take. So I don't think that drug's got a future.
I misspoke on the theophylline mechanism. It is not PD.
Some of these drugs, it almost seems like the primary motivation or indication to use it is how many shares of the stock you have.
Well, the endpoint of 6 months exacerbations.
But I think we can reduce exacerbation. I think there's something worth looking at. I just think that the way it's done is a little bit hard to sort of justify, sort of changing all your patients to this.
Let's say patients on maximum therapy cannot add anything more. Do you have this drug?
I would consider it in that patient, but then again, it's not necessary. It's not how the studies are designed. I'd still consider it.
If you look at the senior staff here, how many of us have started Roflumilast on patients? I haven't done it on any patient.
I've done it on a few and stopped it on all of them.
I've done 3 or 4 on it. I could stop it on all. Again, it's small experience, but yeah.
Side effects and costs.
Most of the side effects.
I tried it on.
Sorry.
So we know that COPD is an inflammatory pathogenesis with high inflammatory markers. And my question is, there was a buzz a couple of years ago on the role of statins, possibly suppressing.
Didn't pan out though. Yeah, they studied it and they didn't find any benefit. In fact, there was even a higher mortality, I think, among COPD group using it.
Can you go back to your first slide for a second? So why are the pre-bronchodilators, I don't know if you mentioned that, but or I missed it, the design. Why are they starting at different levels? Like, were they 2 different characteristic groups?
Not that different though. Look at 1.55 and 1.45. How different is that?
You're talking about less than 200 cc's.
Yeah.
Based on our standards, it's not even considered statistical difference.
And the improvement was 45 milliliters.
Right.
So, yeah.
Okay. Well, I mean, they're just so far, they're so close to each other.
Well, that's the way, how you present the data when you want it to look significant.
Okay.
Everybody spread the axis out, right?
So what were you gonna say?
No, I was just gonna ask you, since you started them and stopped them, were they all in full therapy and stuff? Because that's how I've seen it.
Yeah, and most of the time, it's kind of funny. You start them, everybody's kind of afraid to start something new. Everybody needs a package inserts, so they all want to start slow. And I can't even remember if I got anybody at full therapy before they quit, so just became intolerable.
But they were on Spiriva and
You
ICS
met
and
them
LABA.
Right, I only
You
did
were on the cocktail before you did it.
Exactly, I never used it as a sole
And
thing
it
up
still
front
didn't
here.
help.
Right, it still didn't help. I used it after the maximum cocktail of everything else, right? Maybe that's what I did wrong. Maybe I should want a $300 drug before the cocktail.
But no, that's a good point. So maybe patients who maybe can't take one of these other medications, this might be something, something you maybe consider earlier, rather than just the because again, it hasn't been studied in these patients that are maximized on all the other therapies. And you have evidence to show is helpful.
Okay. So coming down to our final 2 slides. The recommendations for how we are proceeding with our COPD exacerbations I pulled from the GOLD guidelines. And so basically, treatment goals are always to minimize the impact of a current exacerbation to prevent future exacerbations. With antibiotics, we know that patients with type 1 and type 2 exacerbations or require mechanical ventilation benefit the most. Bronchodilators still remain a therapeutic mainstay, and they have been shown to induce long-term improvements in symptoms, exercise capacity, and airflow limitation. With steroids, the data has shown that we have reduced treatment failures, improved lung function, and shortened recovery time. And then oxygen titration, we want to keep them between 88 to 92%. And finally, prevention is always better than cure. So some points to always remember with our COPD patients is smoking cessation, pulmonary rehab, proper use of medication technique, and then vaccinations. Thank you. Stop it.